Severe preeclampsia and imminent eclampsia is an obstetric emergency and must be treated urgently. The treatment is the same as that of eclampsia. In these cases are best managed in a hospital under the supervision of an obstetrician. So while blood pressure reduction is essential, lowering the blood pressure below 140/90 millimeters mercury may cause fetal distress and should be avoided. BP monitoring must be carried out every 15 to 30 minutes until the BP is reduced and the patient is stable. Thereafter, monitoring can be done by 2 to 4 hourly. And daily weighing of the patient is essential. The symptoms are frontal headaches, vomiting, visual disturbances such as double vision, that's diplopia, blurred vision, flashes of light, epigastric pain, and decrease in urine production, that's oliguria. The signs that are usually elicited are elevated blood pressure, liver tenderness, urine production of less than 30 milliliters per hour or less than 400 milliliters per 24 hours. Also, increased tendon reflexes and the presence of ankle ankylosing occasionally. Investigations: FBC, blood clotting profile, bedside clotting time, prothrombin time, INR, APTT, serum uric acid, B creatinine, urinalysis and culture, liver function test, random blood glucose, daily assessment of urine proteins, and ultrasound scan for close fetal growth monitoring. The main treatment objectives are to reduce the blood pressure but not lower than 140/90 millimeters mercury, to prevent the mother from suffering from complications of the hypertension such as a stroke, to prevent fits or eclampsia, to stabilize the patient and deliver her if eclampsia is imminent. Non-pharmacological treatment: so early delivery of mother if eclampsia is imminent. Also, if the patient is not symptomatic and the pregnancy is less than 34 weeks, you allow pregnancy to continue if the fetal condition would allow. If the pregnancy is 34 weeks or more, you consider delivery after stabilization. The pharmacological treatment: BP management in severe preeclampsia and imminent eclampsia. Give hydralazine IV 5 to 10 milligrams slowly over 20 to 30 minutes. Or nifedipine sublingual 10 milligrams that, or labetalol IV 20 milligrams that over at least 1 minute, and repeat at 10 minutes interval if the BP remains more than 160/110 millimeters mercury, as follows: 40 milligrams, 80 milligrams boluses to a cumulative dose of 220 milligrams. When the BP is less than 160 110 millimeters mercury, you commence an infusion of 40 milligrams per hour. You double the infusion rate to as at 30 minutes intervals until satisfactory response or a dose of 160 milligrams 160 milligrams per hour is attained, and then give nifedipine retard oral 20 to 40 milligrams daily, or metaldopa oral 250 to 500 milligrams 8 to 12 hourly. The management or prevention of seizures in severe preeclampsia and imminent eclampsia: give magnesium sulfate IV 20 milliliters of the 20% solution as 4 grams, and magnesium sulfate IM 10 milliliters of the 50% solution, 5 grams into each buttocks with a total of 10 milligrams. The referral criteria: refer all cases of severe preeclampsia and imminent eclampsia promptly to a hospital or obstetrician after the initiation of treatment. When the obstetrician considers that the fetus is immature, the patient should be transferred to a hospital capable of looking after the immature baby.